Welcome to Nurses Lab. In this video, we are going to discuss about the updates released by American Heart Association 2025 guidelines for cardiopulmonary resuscitation and emergency cardiovascular care. This video is summarized from the updates and is purely for educational purpose only. For more details, kindly check with AHA 2025 guidelines. So let's start. This video will highlight the following aspects: ethics, core adult BLS and ALS updates, pediatric BLS and ALS updates, neonatal life support, post-arrest care, cardiac arrest due to special circumstances, and education science. The 2025 update expands and strengthens ethical guidance across resuscitation practice, with a strong emphasis on equity, decision-making, prognostic uncertainty, and support for families and providers. So, first let's see the updates and 2025 guidelines regarding ethics. Ethics is explained into 9 categories. 1. Expanded ethical frameworks. 2. Strong emphasis on equity and social determinants. 3. Clearer guidance on advanced directives and shared decision-making. 4. Updated guidance on initiating, withholding, and terminating resuscitation. 5. Ethical considerations for special populations. 6. Family presence during resuscitation. 7. Ethical use of advanced therapies. 8. Ethical responsibilities in research and knowledge generation. And 9. Impact on providers, survivors, and lay responders. Now let's see one by one. Let's see about expanded ethical frameworks. The AHA now integrates multiple ethical models to guide complex CPR ECC decisions. Principalism, beneficence, non-beneficence, autonomy, justice. Dignity as an explicit ethical value. Narrative ethics, patient story or context. Utilitarianism, maximizing benefit. Virtue ethics, deontology, crisis standards of care for resource-limited situations. This broader framework helps clinicians justify decisions in ethically ambiguous scenarios. Next, let's see about strong emphasis on equity and social determinants. The AHA highlights the ethical imperative to address structural inequities and disparities in emergency cardiovascular care. This includes recognizing how race, socioeconomic status, and access to care affect outcomes, ensuring equitable access to CPR training, AEDs, and advanced therapies, institutional responsibility to reduce disparities. Next, let's see about clearer guidance on advanced directives and shared decision-making. The 2025 update strengthens processes for patient-centered decision-making, respect for advanced directives, early, ongoing shared decision-making with patients or families, transparent communication about prognosis and treatment options, documentation of patient values and goals of care. Next, let's see about updated guidance on initiating, withholding, and terminating resuscitation. The guidelines provide detailed ethical considerations for decisions to start, withhold, continue, or stop CPR. It applies to adults, geriatrics, pediatrics, neonatals, and pregnant patients. Considers prognostic uncertainty and the risk of ineffective therapies. Encourages culturally and religiously sensitive communication, and supports clinicians in ethically justified termination of resuscitation, TOR. Next, let's see about ethical considerations for special populations. Specific guidance is expanded for children, newborns, pregnant patients, and geriatric patients. Each group has unique ethical and prognostic considerations. Next, let's see about family presence during resuscitation.
The AHA continues to support family presence during resuscitation when feasible, emphasizing respect for family needs, structured support for families and staff, and minimizing interference with care. Next, let's see about ethical use of advanced therapies. The guidelines address ethical issues related to extracorporeal CPR, eCPR, mechanical circulatory support, and organ and tissue donation. Focus: balancing benefit, resource use, and patient values. Next, let's see about ethical responsibilities in research and knowledge generation. The AHA highlights ethical conduct of resuscitation research, protection of vulnerable populations, and transparency in data use and consent processes. Finally, let's see about impact on providers, survivors, and lay rescuers. The guidelines acknowledge the emotional and psychological impact of resuscitation on healthcare professionals, survivors, families, and lay rescuers. Ethical duty: provide support, debriefing, and mental health resources.
Cardiac arrest doesn't care where you are: home, street, ward, or ICU. For years, the guidelines gave us different chains of survival for each setting and age group. In 2025, that changed. There is now one unified chain of survival for all cardiac arrests, adults and child, in hospital and out of hospital. In this video, we'll break down this new chain, compare it with the 2020 model, and show you how to build better workplace drills around it. The chain of survival is a simple way to describe the sequence of actions that give a cardiac arrest patient the best chance at survival. Recognize the arrest, call for help, start high-quality CPR, deliver early defibrillation, provide advanced life support, and finally, post-arrest care and recovery. If any one of the above is weak, everything downstream suffers. In the 2025 AHA guidelines, the chain of survival has been unified. Instead of different chains for adults versus pediatrics or in-hospital versus out-of-hospital, we now has one 6-link chain that applies to adult and pediatric patients, in-hospital and out-of-hospital cardiac arrest, lay rescuers and professionals with minor adjustments. Let's look at each of these one by one. Recognition and activation. No response, not breathing normally or only gasping, that's cardiac arrest until proven otherwise. For lay rescuers, call EMS and put the phone on speaker. In hospital, hit the code button, call the rapid response or code team, and shout for help. High-quality CPR. Hard, fast compressions, full recoil, minimal interruptions. Adults compress at least 1/3 of chest depth, about 5 to 6 centimeters. For children and infants, depth is still 1/3 of chest, but the technique and hand position will differ. Rapid defibrillation for shockable rhythms. Out of hospital, that means AEDs everywhere: offices, malls, schools. In hospital, it means that defibrillator pads are applied early and someone is clearly assigned as the defibrillation nurse or doctor during codes. Advanced life support: airway, oxygen, access, drugs, rhythm check, and reversible causes. This is where ACLS and PALS algorithms come in: epinephrine timing, antiarrhythmics, and treating H's and T's. Post-cardiac arrest care. Once you get ROSC, the work is far from over. Optimize oxygen and blood pressure, treat the underlying cause, consider coronary intervention, brain protection, and targeted temperature control as per protocols. Recovery and survivorship. The 2020 guidelines added recovery as a 6th link. 2025 continues that focus and folds it into the unified chain. Recovery means physical rehab,
cognitive and psychological support, and follow-up for the patient, and debriefing and mental health support for the team. So what actually changed between 2020 and 2025? 2020 gave us 4 separate chains: adult versus pediatric, in-hospital versus out-of-hospital, and added recovery as a 6th link. 2025 keeps those same critical steps but merges them into one unified chain for all cardiac arrests. Remember, neonates now have a separate newborn chain of care that starts even before birth, with prenatal care, delivery planning, and postnatal follow-up.
Now we are going to see about adult choking response. The latest guidance emphasizes a cycle of 5 back blows followed by 5 abdominal thrusts for severe choking in responsive adults. This method replaces older Heimlich-only approaches and is repeated until the obstruction is cleared or the person becomes unresponsive. Use the new 5 and 5 cycle only for severe choking, when the person cannot cough, speak, or breathe. So let's see how it works. Step 1. 5 back blows. Support their chest, lean them forward, and deliver 5 strong blows between the shoulder blades. The forward tilt uses gravity to help dislodge the object. Step 2. After the back blows, move into 5 abdominal thrusts. Place your fists above the belly button, below the sternum. Pull inward and upward sharply. These compressions generate a sudden rise in airway pressure to push the object out. Now repeat this 5 and 5 cycle continuously. 5 back blows, 5 abdominal thrusts, repeat, until the obstruction comes out or the person becomes unresponsive. So let's see, why this change? Evidence shows that combining 2 different force mechanisms, back blows and thrusts, increases airway pressure variability and improves the chance of expelling the obstruction. The method is safer, more effective, and easier for responders to remember. Next, we are going to see about what to do if the person collapses and unresponsive. In this case, switch to CPR immediately. Activate EMS, start chest compressions, and every time you open the airway, quickly look for the object. Remove it only if you can see it. Never perform blind sweeps. Remember, 5 back blows, 5 abdominal thrusts, repeat until the airway clears or the person becomes unresponsive. Opioid overdose is one of the most common causes of preventable respiratory and cardiac arrest. In basic life support, naloxone has a very specific place in the algorithm, but it never replaces CPR or defibrillation. Let's walk through exactly when and how to use naloxone. When to suspect opioid overdose. When you see a person with slow, shallow, or absent breathing, pinpoint pupils, unresponsiveness, drug paraphernalia nearby, and known opioid use. Let's see about breathing versus non-breathing. What to do when a person is not breathing or only gasping. If the person is not breathing or only gasping, treat it like cardiac arrest. Start CPR immediately. In case of a person who is breathing but unconscious, provide rescue breaths and administer naloxone. If they have a pulse and are breathing inadequately, you start rescue breaths and give naloxone right away. Let's see BLS with cardiac arrest. In cardiac arrest, your priorities do not change. First, high-quality CPR. Then, attach AED and deliver shocks if indicated. Then, activate EMS. Then, consider naloxone. Naloxone is helpful only if opioids are contributing, but it must never delay compressions or defibrillation. In the BLS cardiac arrest algorithm, naloxone appears after CPR and AED are underway. This means start compressions immediately, apply AED,
And when you have a spare rescuer or during a natural pause for ventilation, administer naloxone. What to do if the person has a pulse but is not breathing? First, give rescue breaths, 1 breath every 5 to 6 seconds. Then, give naloxone immediately. This is where naloxone has its greatest impact. Then, continue rescue breaths until spontaneous breathing returns. Because in opioid overdose, respiratory arrest usually comes before cardiac arrest, naloxone can prevent deterioration. Let's see naloxone storage and its types. Naloxone can be stored in first aid kits, AED cabinets, EMS bags, and hospital code cards. It comes as nasal spray, most common in BLS, IM injection, which requires training, and auto-injector. Always check expiry and protect from extreme temperatures. Naloxone dosage and routes of administration. For most BLS settings, use nasal naloxone 4 milligrams. First, peel the package, then insert into one nostril, and then press the plunger. Then resume CPR or rescue breaths immediately. If using IM naloxone, draw up 0.4 to 2 milligrams. Inject into the thigh or deltoid. Then continue CPR or rescue breaths without delay. Post-naloxone administration. Naloxone works within 1 to 3 minutes. Continue BLS care while watching for improved breathing, increased responsiveness. You may repeat naloxone every 2 to 3 minutes if there's no improvement. Be prepared. When naloxone wears off, the person may stop breathing again. Keep monitoring continuously. Survival in cardiac arrest depends on precision, timing of epinephrine, timing of shocks, and disciplined rhythm cycles. Today, we'll walk through a refined megacode demonstration to show how timing, teamwork, and feedback transform performance. Modern code teams focus on 3 timers: 2-minute CPR cycles for rhythm checks, 3 to 5-minute epinephrine windows, and immediate shocks for VF or PVT. In this video, we'll show how to execute all 3 flawlessly. Our megacode team consists of 6 roles. Every role tracks one part of the algorithm, eliminating delays, errors, and missed doses. They are team leader, compressor, AED/defibrillator lead, airway manager, medication nurse, recorder/timer. The moment cardiac arrest is recognized, begin compressions, attach defibrillator pads, switch on timer. Shockable rhythms. VF and pulseless VT is considered as shockable rhythm. If the rhythm is VF or pulseless VT, your priority is immediate shock delivery, not epinephrine yet. When prompted, deliver the shock and resume compressions instantly. No pulse checks, no delays. Now let's see about epinephrine. In shockable rhythms, epinephrine begins after the second shock, usually 3 to 5 minutes into the code. This prevents unnecessary delays and keeps the focus on defibrillation early. After the second shock, give 1 milligram epinephrine, log the time, and set a 3 to 5 minute repeat timer. Now the recorder will announce epinephrine next dose window 3 to 5 minutes from now. If VF persists through the third shock, the team may give an antiarrhythmic, such as amiodarone or lidocaine. CPR continues. The cycle of CPR, rhythm check, shock, CPR continues without interruptions. In case of pulseless electrical activity, PEA, if the rhythm becomes PEA or asystole, epinephrine is given immediately and every 3 to 5 minutes thereafter. Rhythm checks only occur at the end of each 2-minute CPR cycle. Refined cardiac arrest management depends on clear, consistent team roles. Compressor changes every 2 minutes. Defibrillator lead owns shocks and charging. Medication nurse owns epi countdown. Airway manages oxygenation and EtCO2 monitoring. Recorder runs timers and announces cycle transitions. Team leader directs coordination and anticipates next steps. Good teams operate like a synchronized unit, not 6 individuals. High-level megacode performance requires feedback-based training. CPR feedback devices, depth, recoil, and rate. EtCO2 monitoring identifies ROSC early. Real-time timers prevent epinephrine delay. Pre-charging defibrillator eliminates wait time. Debriefing software identifies algorithm gaps. Let's see about return of spontaneous circulation, ROSC. Once ROSC is achieved, optimize oxygen and ventilation, check BP and perfusion, manage temperature, and search for reversible causes. Teams should shift from crisis mode to post-resuscitation care seamlessly.
Now let's see about role assignment during megacode. High-performance teams use fixed roles, assigned instantly. Compressor, defibrillator manager, airway manager, medication nurse, recorder/timer, team leader. This structure reduces overlap, delays, and confusion. Closed-loop communication. Team member repeats orders clearly. For example, timer announces epinephrine due time. The team leader uses closed-loop communication, ensuring every medication order is repeated back and time-stamped. 2-move anticipation. This is one of the key steps the team leader as well as the recorder anticipate and predict. Leadership now emphasizes 2-move anticipation, predicting the next rhythm check, drug, or shock before it's needed to tighten the flow of the megacode. The 2025 update reinforces that PALS is not just a code response course, it is a recognition and escalation system. Cardiac arrest in infants and children is not usually result from a primary cardiac cause. It is probably the result of progressive respiratory failure or shock. High-quality CPR and early defibrillation for shockable rhythms together are the cornerstone of treatment for pediatric cardiac arrest. For infants and children in cardiac arrest, interruptions in CPR should be minimized and pauses in chest compressions should be less than 10 seconds. Stronger emphasis on early recognition. Pediatric arrests usually follow respiratory failure or shock, so early identification is critical. Teams should drill on work of breathing, perfusion indicators, mental status changes. Focus on preventing arrest, not just treating it. 2025 updated PALS algorithms. The AHA released refreshed 2025 algorithms for pediatric resuscitation, including Pediatric BLS, Single Rescuer and Team, Pediatric Advanced Life Support, Pediatric Special Circumstances. System pathways and rapid transfer. The 2025 guidelines highlight the need for system-level readiness, rapid escalation pathways, clear transfer routes to definitive pediatric care, visible and testable handoff processes. This aligns with the AHA's push for team-based, systems-oriented pediatric emergency care. Integration with BLS and ACLS changes. Although pediatric care is unique, PALS now aligns more closely with updated BLS choking sequence, 5 back blows and 5 abdominal thrusts for adults, relevant for mixed-age settings, and naloxone placement in BLS, important for adolescents. Focus on prevention over reaction. The 2025 PALS update stresses early recognition, early respiratory support, early shock management, early escalation. This shift reflects pediatric epidemiology. children rarely have sudden primary cardiac arrest. 2025 updates. Let's see the algorithm for single rescuer and 2 or more rescuers. Changes in this update is: for infants and children in cardiac arrest with initial non-shockable rhythm, it is reasonable to administer the initial dose of epinephrine as early as possible. For infants and children with invasive airways in place during CPR, end-tidal carbon dioxide monitoring may be considered to monitor CPR quality. For infants and children with continuous invasive arterial blood pressure monitoring in place during CPR, it may be reasonable for healthcare professionals to target a diastolic blood pressure of 25 mm Hg or greater in infants and 30 mm Hg or greater in children 1 year of age or older. Supraventricular management. For infants and children with supraventricular tachycardia and cardiopulmonary compromise unresponsive to vagal maneuvers, adenosine, and electrical synchronized cardioversion, and for whom expert consultation is not available, it may be considered to administer intravenous procainamide, amiodarone, or sotalol. Post-cardiac arrest management. After cardiac arrest in infants and children, AHA recommends to maintain systolic and mean arterial blood pressure greater than the 10th percentile for age. Prognostication following cardiac arrest. AHA recommends the usefulness of cough or gag reflexes or response to pain to support a favorable or unfavorable neurological prognosis at any point of time after cardiac arrest in infants and children. It is also recommended for reasonable to use electroencephalography, EEG, up to 72 hours after cardiac arrest in infants and children to support a favorable or unfavorable neurological prognosis. Post-cardiac arrest recovery and survivorship. AHA recommends infants and children who survive cardiac arrest must be evaluated for physical, cognitive, and emotional needs to guide follow-up care within the first year following cardiac arrest. 2025 Neonatal Life Support Updates. The 2025 Neonatal Life Support chapter is a comprehensive evidence update since 2020, not a minor tweak. Includes 4 new systematic reviews, 2 new scoping reviews, evidence updates for many other topics along the algorithm: airway, ventilation, circulation, drugs, post-resuscitation care. Whole algorithm is focused on from birth transition to post-resuscitation. The 2025 NLS/NRP guidance explicitly addresses all components of the neonatal resuscitation pathway, physiology of newborn transition, emphasizes the critical interdependent changes in breathing, circulation, shunt closure, and pulmonary blood flow in the first minutes of life. Every step of the algorithm are determined based on the evidences collected by the researchers in AHA are as follows: initial assessment and stimulation, airway positioning and opening, positive pressure ventilation strategies, oxygen use and titration, chest compressions, medications, temperature control, and post-resuscitation care. Now let's see the key updates of AHA 2025 guidelines regarding neonatal life support. The newborn chain of survival care process starts with prenatal care and extends up to recovery and appropriate follow-up in the postnatal period. Newborn resuscitation requires anticipation and preparation by healthcare professionals who train individually and as teams. Most newborn infants can be evaluated and monitored during deferred cord clamping for 60 seconds or more, when maintaining skin-to-skin contact with a parent after birth. Effective ventilation of the lungs is the priority in newborn and infants who need resuscitation. AHA
also added some new recommendations such as positioning for chest compression, timing of pulse oximeter placement, and ventilation corrective steps, which probably these practices are already be commonly performed, but have been added with review of the latest evidence. Ventilation corrective steps, which include use of an alternative airway like a laryngeal mask or endotracheal tube, may be required if the heart rate does not rise with face mask ventilation. Now let's see the AHA recommendations for newborn resuscitation. Umbilical cord management. For term newborns who do not require immediate resuscitation, deferred cord clamping for at least 60 seconds can be beneficial when compared with immediate cord clamping. For newborns with non-vigorous term and late preterm infants, 35 weeks or more gestational age, milking of cord may be reasonable when compared with immediate cord clamping. For newborns who born at less than 37 weeks of gestation and who do not require immediate resuscitation, deferred cord clamping for at least 60 seconds is recommended by AHA 2025 update when compared with immediate cord clamping. Ventilation and continuous positive airway pressure. For newborns, while providing ventilation, initial peak inflation pressures of 20 to 30 centimeters H2O are reasonable. With adjustments of peak inflation pressures, we can provide effective ventilation. AHA recommends to provide ventilation at a rate of 30 to 60 per minute in newborn infants. It also recommends to use video laryngoscopy for endotracheal intubation in newborns. It is advisable to use a laryngeal mask as an alternative solution for endotracheal intubation for newborns at 34.0/7 weeks of gestation or more for whom ventilation via face mask is unsuccessful. Oxygen. To monitor the oxygen saturation, a pulse oximeter should be placed as soon as possible for newborns receiving respiratory support or supplemental oxygen through any oxygen delivery devices. In preterm newborns born at less than 32 weeks of gestational age, receiving respiratory support at birth, it is recommended by AHA to start with 30 to 100% oxygen. Chest compressions. For chest compressions in newborns, AHA recommends to compress over the lower third of the sternum. Care to be taken, it should be above the xiphoid process when providing chest compressions to newborns, and to switch compressors when heart rate is being assessed. The 2025 revisions enhance outcomes through tighter sequencing of epinephrine and antiarrhythmics, airway prioritization, effective BMV before advanced airways, pre-charge defibrillation pathways, structured megacode leadership, feedback device incorporation, and new emphasis on early post-arrest care. 2-move anticipation. Survival doesn't end at ROSC. The 2025 updates reinforce early, aggressive post-arrest care. Optimize oxygenation, avoid hyperventilation, maintain MAP targets, correct underlying cause, for example, STEMI to immediate PCI, temperature management depending on institutional protocols, seizure monitoring, controlled ventilation with ETCO2 monitoring. Essentials of megacode. Epinephrine after second shock, VF or PVT, immediate epi, PEA or asystole, amiodarone or lidocaine after third shock, pre-charge shocks, closed-loop communication, roll clarity, feedback devices, ETCO2 for airway plus ROSC detection, strong post-arrest bundle. Strategies behind airway and defibrillation. Cardiac arrest management hinges on 2 pillars: airway, bag mask ventilation versus supraglottic versus endotracheal tube, and defibrillation, immediate, synchronized, and timed pathways. Let's walk through each with updated recommendations. Airway Updates in 2025 highlights. Early airway focus is shifting toward effective bag mask ventilation. Advanced airways should not delay first chest compressions, first shock, and early epinephrine. If high-quality BMV is effective, advanced airway placement can be deferred. Supraglottic airway as first advanced option. When upgrading from BMV, supraglottic devices are often the quickest, most reliable step in both in-hospital and pre-hospital settings. They also minimize interruptions and require fewer attempts. Endotracheal intubation, when to choose it. Endotracheal intubation remains the gold standard when performed by skilled providers. Consider ET tube when airway protection is needed, aspiration risk is high, ventilation is difficult, and extended transport or prolonged resuscitation is expected. Use waveform capnography to confirm each breath. Now let's see about the defibrillation strategy updates. Shockable rhythm means shock immediately. The defibrillation message is unchanged and reinforced. For VF or PVT, deliver the first shock immediately. Charge the defibrillator while compressions continue. Pause only to shock. Pre-charge strategy. During the last 10 seconds of a CPR cycle, pre-charge so the next shock is instantaneous. This reduces hands-off time and dramatically boosts shock efficacy. Energy settings and pad placement. Biphasic shocks remain standard. First shock, 200 joules biphasic. Subsequent, escalate as needed. For refractory VF, consider anterior-posterior pad placement or vector change. Double sequential external defibrillation. Emerging guidance supports double sequential defibrillation for persistent VF after multiple failed shocks. This technique requires trained teams and specific protocols. Next, let's discuss about the drugs which are known to be the pillars of pharmacology used in the ACLS: epinephrine, antiarrhythmics, and reversible causes meds. First, let's see about epinephrine, precise timing and sequencing. While monitoring for VF and when the rhythm shows VF or VT, shock will be delivered and the timer starts to count for the next cycle. During this time, that is exactly after second shock, epinephrine will be administered. During non-shockable rhythms, in PEA or asystole, epinephrine is given right away, then every 3 to 5 minutes. A timer should be assigned to ensure doses are never missed. Next, let's see about antiarrhythmics. For persistent VF or pulseless VT, after the third shock, the team administers an antiarrhythmic, VF or PVT. Amiodarone, 300 mg IV or IO, first dose, followed by 150 mg if VF persists, or lidocaine 1 to 1.5 mg per kilogram as equivalent first dose with 0.5 to 0.75 mg per kilogram repeats. Both remain acceptable depending on availability and local protocols. Special medications for reversible causes. To treat the reversible causes for 5Hs and 5Ts, the following medications are used. For example, hyperkalemia to calcium chloride, opioid overdose to naloxone, and hypoglycemia to dextrose.
Post-arrest care. Airway and defibrillation decisions affect what happens after ROSC, not just during arrest. Key post-arrest priorities include oxygen titration, blood pressure support, ECG for ischemia,
immediate PCI if needed, temperature management, seizure monitoring, avoiding hyperventilation. The care pathway must continue seamlessly after return of circulation. So let's see the 2025 updates post-cardiac arrest care. Blood pressure in adults after cardiac arrest. In adults following return of spontaneous circulation, ROSC, hypotension should be prevented by ensuring that the mean arterial pressure, MAP, remains at or above 65 mm mercury. Diagnostic studies for adults after cardiac arrest. Conducting a head-to-pelvis computed tomography scan in adult patients following return of spontaneous circulation, ROSC, can be appropriate to assess the underlying cause of cardiac arrest and identify any complications arising from resuscitation. Performing echocardiography or point-of-care cardiac ultrasound in adult patients following ROSC may be appropriate to detect clinically important conditions that require intervention. Temperature control for adults after cardiac arrest. It is appropriate to maintain temperature control for a minimum of 36 hours in adult patients who remain unresponsive to verbal commands following return of spontaneous circulation, ROSC. Percutaneous coronary intervention for adults after cardiac arrest. For adult survivors of cardiac arrest who are suspected to have a cardiac cause, especially those presenting with an initial shockable rhythm, unexplained left ventricular systolic dysfunction, or signs of significant myocardial ischemia, coronary angiography is advised prior to hospital discharge. Temporary mechanical circulatory support for adults after cardiac arrest. In carefully chosen adults who experience refractory cardiogenic shock following cardiac arrest and return of spontaneous circulation, ROSC, the use of temporary mechanical circulatory support can be considered. Diagnosis and management of myoclonus in adults after cardiac arrest. It is not recommended to treat myoclonus without an EEG correlate in adult survivors of cardiac arrest. Neuroprognostication. When assessed alongside other prognostic tools, the presence of a continuous EEG background without discharges within 72 hours following cardiac arrest can be reasonably considered as supportive evidence for a favorable neurological outcome in adult patients who remain comatose after return of spontaneous circulation. Recovery and survivorship after cardiac arrest. Cardiac arrest survivors and their caregivers should receive a structured evaluation and either treatment for emotional distress or a referral to appropriate support services following medical stabilization and prior to discharge from the hospital. Now let's see about the next component, cardiac arrest due to special circumstances. Certain unique situations may require interventions that go beyond standard basic and advanced life support protocols. These guidelines are designed to address the care of both children and adults facing life-threatening emergencies, such as cardiac arrest. Major new and updated recommendations. Life-threatening asthma exacerbation. Employing ECLS may be appropriate for both adults and children experiencing severe, life-threatening asthma that does not respond to conventional treatments. Volatile anesthetics may be considered as a treatment option for adults and children experiencing life-threatening asthma that does not respond to conventional therapies. Life-threatening hyperkalemia. The efficacy of intravenous calcium administration for adults and children experiencing cardiac arrest due to suspected hyperkalemia remains uncertain. Life-threatening hypothermia. It is appropriate to use prognostication scores to assist in determining whether to initiate ECLS rewarming for hypothermic cardiac arrest in adults and children. Adults and children experiencing life-threatening hyperthermia should be cooled as quickly as possible targeting a decrease of at least 0.15 degrees Celsius per minute or 0.27 degrees Fahrenheit per minute. Left ventricle assist devices.
For unresponsive adults and children with durable LVADs and evidence of inadequate perfusion, performing chest compressions is recommended. Similarly, for unresponsive adults and children with durable LVADs and signs of impaired perfusion, it may be reasonable to initiate chest compressions promptly while concurrently evaluating for reversible device-related causes. In the 2025 updates, AHA has made an algorithm for left ventricular assist devices usage.
Cardiac arrest during pregnancy. Preparation for resuscitative delivery in a pregnant patient should begin immediately upon recognition of cardiac arrest, aiming to complete the delivery within 5 minutes. It is reasonable, according to the American Heart Association, to consider eCPR for pregnant or peripartum patients in cardiac arrest who do not respond to standard resuscitation efforts. For peripartum patients with suspected life-threatening amniotic fluid embolism, a massive transfusion protocol using a balanced transfusion strategy should be implemented. Toxicology, opioid overdose. For both lay and trained rescuers, administration of an opioid antagonist may be reasonable for adults and children in cardiac arrest with suspected opioid overdose, as long as it does not delay or interfere with standard resuscitation measures, including high-quality CPR with ventilations. Adults and children treated for opioid overdose should be provided with an opioid antagonist, for example, Naloxone, and education on its use at the time of discharge from a healthcare facility. Now let's move on to the final topic in our video about education science. Advances in education, training science, and technology have prompted a comprehensive literature review, resulting in several important updates for both healthcare professionals and lay rescuers. Key areas of change include recommendations on training feedback devices, reducing disparities in CPR education, incorporating virtual reality, VR, and improving lay rescuer education for opioid overdose. Use of feedback devices during CPR training. Feedback devices are recommended for use during CPR training for both healthcare professionals and lay rescuers. Rapid cycle deliberate practice. It may be appropriate to include rapid cycle deliberate practice as a component of BLS or ALS training for healthcare professionals. Teamwork and leadership training. Life support training for healthcare professionals should include a specific focus on developing teamwork competencies. Gamified learning. The use of gamified learning elements may be appropriate as part of resuscitation training for healthcare professionals and as a component of CPR education for lay rescuers. Virtual reality and augmented reality. It may be reasonable to use virtual reality, VR, to support knowledge acquisition in BLS and ALS training for both lay rescuers and healthcare professionals. The use of augmented reality to provide real-time CPR feedback may be considered for BLS training of lay rescuers and healthcare professionals. Virtual reality should not be used as a method for teaching CPR psychomotor skills for lay rescuers or healthcare professionals. Opioid overdose training for lay rescuers. Lay rescuers should receive education on recognizing and initiating treatment for individuals experiencing an opioid-associated emergency. The optimal training approach for lay rescuers to identify and respond to opioid overdose has not yet been established. Disparities in education. CPR training for lay rescuers should be tailored to specific racial and ethnic populations and targeted toward neighborhoods with high concentrations of these groups, incorporating focused awareness efforts. Efforts should address barriers in linguistically isolated communities by improving access to multilingual CPR materials and promoting cost-effective, safe training opportunities for low socioeconomic settings. CPR training in school children. It is recommended that CPR training begin in children younger than 12 years of age to enhance their willingness and self-confidence to respond in later years. Alternative objects for chest compression training in lay rescuers. The effectiveness of using alternative objects for training lay rescuers in chest compressions compared with a mannequin has not been well established. Scripted debriefing. It may be reasonable for instructors to incorporate a debriefing script as part of resuscitation education. Use of cognitive aids. The use of cognitive aids during resuscitation may be reasonable for healthcare professionals. However, it is not recommended for lay rescuers.
Thank you for watching. For more details, visit www.nurseslab.org. We will see you in our next video with detailed 2025 ACLS algorithms. If you like this video, please subscribe our channel and support us.